Hi, my name is Dr. Robina Smith, and I'm a breast cancer surgeon. My specialty actually is oncoplastic breast surgery. What is that, you ask? Well, it's merging two types of areas of surgery together. It's plastic surgery or reconstructive surgery merged with a cancer operation. And it stems from my background as being an artist. I started off as a medical illustrator. I freelanced for my own company as a graphic artist as well for several years, well before the desire to want to work with people, the desire to want to be a breast cancer surgeon. And ever since I met a female breast surgeon, she changed my life, and I had a newfound desire to want to work with women. Breast cancer is one of the diseases that is amazing to me because it's the second leading cause of cancer death in women and the leading cause of death in young African American women under 45, and we have no cure. We spend millions and millions of dollars every year with walks and runs and pink ribbons and everything pink in October, yet we haven't found a cure. So my passion is with breast cancer, with working with women, getting them over and through and beating breast cancer is my passion. Education and awareness is all that we have. Early detection is cure. And my stance is to get out there and try to educate as many women as possible about their risk of breast cancer so that they know their risk and then they know how to beat it. Every woman has a risk. The two biggest risk factors for breast cancer is just being a woman and having breasts and getting older. And those are the two that are not modifiable. We can't change our sex. We can't change getting older. So what happens is we have to monitor. We have to monitor for these changes because we know that there's a risk. My background is interesting because I had no desire to be a doctor. I was an artist and I loved biology, and I merged those two together when I found out about medical illustration. When I was in my training for medical illustration, I had to go into the operating room as an artist to draw surgeries, and that was fascinating to me. And I got bit by the surgical bug. I did my general surgery residency in Brooklyn, New York. I did my medical school in Philadelphia, and I came out here to California to do my fellowship at USC. And since then, I've been working for a medical group in Northern Orange County where I work exclusively with breast cancer patients only. I'm a fellowship-trained, dedicated breast cancer surgeon. One of the things that I find exceedingly difficult to do is encourage my patients when I'm giving them the diagnosis of breast cancer. And rightfully so, it's a scary thing, and I know it. But one of the gifts that I have is the ability to connect with my patients and to encourage them to know that they can fight and they could be an active participant in their treatment. Once we've decided that we want to beat this thing, we have to really believe that this is something that we can overcome, and you need to be encouraged. And that's what I love to do for my patients. And one of the hardest obstacles always is feeling like you can win. But I'm here to let you know that if you fight and you believe that you can win, and you have a good support system, then you will win. Most women who have, 80% of women who have a breast biopsy, the results are going to be benign, a benign lump, something like a fibroadenoma, benign breast tissue, not cancer. Only 20% of the women who have a biopsy will have a cancer diagnosis. So a lot of women get biopsies and it's not cancer. So your mass or whatever they biopsy was probably benign, and then they probably also happen to see same atypical cells. So whenever we see a little portion of atypical cells, we want to go back in and remove everything to make sure that it's only atypical cells and nothing else. And so we always recommend after a needle biopsy, surgery or an excisional biopsy, just to get a larger area, just to make sure that there's nothing else going on. So that's appropriate. But after removing that area, that doesn't take away your risk. If you had atypical cells seen in your milk ducts, you're considered high risk. And what we do for women who are high risk, you should have an annual mammogram. You should have clinical breast exams every 6 months by a breast specialist, and you yourself should be doing self-breast exams. That's the recommendation. We also sometimes can actually calculate. Remember I told you I was going to calculate your risk? We can calculate what your perceived lifetime risk of breast cancer is based upon your atypical changes in your breast, your family history, when you started your period, if you've ever been on hormones, things like that. And if your risk is calculated to be 20% or higher, we can also add an annual MRI as part of your screening.
Does the MRI see it better?
MRI is a very sensitive exam. Sometimes it is too sensitive, meaning it can overcall and it can lead to unnecessary procedures and biopsies, but it can also see things that are missed by mammogram and ultrasound. It can find earlier cancers. And so it's a really sensitive tool, but it does lead to a lot of unnecessary biopsies and anxiety sometimes. But it's a good, it's too expensive to use, and it's not specific enough to use as a screening for all women like mammogram. Okay. But for high-risk women, women who have the breast cancer gene, women who have atypical or high-risk lesions, if you have dense breasts and lumpy, bumpy breasts and it's hard to figure out what's going on, or if you have implants, MRI is a good imaging modality that can aid to a mammogram and ultrasound.
And how often is the
MRI? Annually. So what I do for my high-risk patients is that they'll have an annual mammogram, an annual MRI, but I space it out so that every 6 months they are having an image. Exactly. And then you have clinical breast exams every 6 months. One of the things I find interesting is the fact that most women don't understand that they can make a difference in detecting breast cancer. Performing a self-breast exam every month is like one of the easiest things a woman can do. Once a month, get to know your breasts. Don't be afraid to touch your breasts. I tell my women, you should treasure your chest. You should do a self-breast exam. Nobody knows your breasts better than you. The second thing that's important is that you should have an exam done by a physician once a year when you have your annual exam. And the third thing that's important, if you're a woman over 40 or you have a strong family history, you should start having annual mammograms starting at the age of 40. These are the only 3 things that we have that can help us detect breast cancer. What happens is usually we pick up these atypical changes by calcifications on a mammogram or some abnormality, right? So we biopsy, so we take a sample with a needle of that. And then with the needle tissue, we actually look under a microscope and we see these changes. By the mere fact that you're telling me they did it with an ultrasound, that means it had to be a mass or some kind of lesion that they can see with ultrasound. And when they biopsied that area, they only took a portion of that abnormality out with the needle. The needle only takes little cores. That's why it's called a core biopsy. They took the portion out. They looked at it under a microscope. After the biopsy, they put a little clip in the area to mark the spot where they were. And then the pathologist looks at those little cores and says, okay, within these cores, I see these changes. And so you probably had some benign breast tissue, some benign things going on, and probably some incidental atypical changes, because most of these atypical changes that we see don't make masses.